Talk from Karen Davis. You've already met Karen Davis, and it's obvious to you that she's a passionate, pragmatic policy expert and also, in her own right, an expert academic. She's been an advisor to presidents, and she's the president of the Commonwealth Fund, and we're delighted to have Karen with us today.
Thank you, David, and thanks to all of our panels and all of you for being here. Often I'll have a role as a rapporteur in a meeting, and I'll take extensive notes and then try to synthesize it, but I'm not going to do that today, but I'd like to walk you through a little bit of perspective on this broad issue of how we can speak the same language, share with you, since I never miss an opportunity to communicate the work of the Commonwealth Fund, share with you a little bit about some of our work, and then turn to my assigned task of what are some actionable steps that the various stakeholders assembled in this room can take. So to start, I would really like to focus on this issue that I care passionately about, how to achieve a high-performance health system, give some information on how we're now faring, what kind of research I think would be particularly useful in getting us to what I call a 2020 vision of the American healthcare system. I published this in 2000, so I'm very focused on getting there, and we now only have 8 years left. To give some specific examples of work that we're supporting, and then turn to my assigned task. The strategy for achieving a high-performance health system, as I mentioned, the overall strategy, our board decided to gather some of the best minds together to work on this issue and give them the charge, before there was a widely known triple aim of yielding better access, improved quality, and lower cost. Our Commission on a High-Performance Health System was originally chaired by Dr. James Mongan at the Partners Healthcare System, somebody I had worked with in the Carter administration and had known over the years. He was also behind the scenes instrumental in the Massachusetts health reforms. He had one hat that said CEO of the Partners Health System. He had one hat that said President of the Boston Chamber of Commerce. As a major employer, one hat as head of the Commonwealth Fund Commission on a High-Performance Health System, and behind the scenes was very instrumental in the Massachusetts health reform. With his passing, Dr. David Blumenthal has assumed the chair of our Commission on a High-Performance Health System. I mentioned him earlier in some of the work that we had supported that he had done, but most recently was the nation's IT czar, health information technology, and now taking on that role. The Commission came out with a report on a framework for a high-performance health system, but most importantly, what are the strategies for getting there? And they said you need to have everybody covered. It's just hard to get to high performance if you don't have affordable health insurance and affordable care for everyone. You need to reward what you want to see happen. You have to align the financial incentives with the behavior you'd like to have. You need to reform the delivery system, and I would say this has been our major contribution, that you can't keep delivering care in silos. With the assumption that a physician will know everything and provide the right care on their own, that you need to be embedded in a system that supports high-performance care, and a commitment at all levels to quality improvement and innovation. And you need everybody working together, public and private sector, I would say in this meeting, funders, researchers, those policy officials, and those delivering care to really get the results. I said I would share with you some of the work that's been done, particularly under our commission on a high-performance health system. The first thing we did was a national scorecard called Why Not the Best, was actually a term that was stolen from Jimmy Carter. But it turned out to have power. We've talked here about actionable information. But to me, the power has been comparative data. I love this joke about partial baseball scores, and then they only read off the results of one team. And it doesn't help you very much unless it's this versus that. You don't know. And furthermore, when we did these scorecards, not only did we compare the various states or the various hospitals, or most recently, the various local areas, we focused hard on the high performers. We took, first of all, we set the scores at the 90th percentile. What did the best 10% do? And how much would be gained if everybody came up to the 90th percentile? And then we had lots of examples, companion reports on the high performers. And somehow that works so much better than pointing fingers at Oklahoma, where I'm from, or the low performers that sometimes the media kind of gets into, but the media really got into this high performance story. So the good news for Michigan is that they're 20th, certainly above the median, better than New York, better than Ohio, but not quite so good as Iowa or Wisconsin. So ways that they can improve, can bring their performance. And these scores are based on anywhere from 40 to 60 indicators of health system performance following the framework that our commission set out of access, quality, prevention and treatment, avoidable costs, equity, and health outcomes. Just very recently, we released a local scorecard on health system performance for this 306 different hospital referral regions in the U.S. It's the first time there have ever been data published at this level on commercial health expenditures per capita. We've all seen the Dartmouth Atlas with Medicare spending per capita. So one of the big results of this local scorecard was really being able to pull together both the elderly experience and the working population experience. Again, Ann Arbor, not quite at the top, but not at the bottom, and a lot of variation. And then as you can drill down within this report at areas, for example, within Michigan, you see Ann Arbor again in the middle, not quite as good as Grand Rapids, but better than Detroit, if that's a sense of comfort to anyone. But the main issue is to find out what they're doing in Grand Rapids that gets them better scores. I've now made a home in Toledo, Ohio, as well as New York, so we have a ways to go to catch up with Ann Arbor. And our board heard some very exciting results this week from Cincinnati and what they're doing at the community level and with patient-centered medical homes. So again, lots of information. I encourage you to go and look at it. One issue that we've been particularly involved in at the Commonwealth Fund, and we are funding, as I'll mention just in a minute, the state of Michigan, among others, to reduce hospital readmissions. Our first scorecard on Why Not the Best found that Medicare spending per beneficiary was highly correlated with hospital readmissions. It was very shocking to us to find that single indicator predicted a lot of the variation in Medicare spending geographically, and it has led to a whole national movement to be concerned about hospital readmissions. And in the Affordable Care Act, there are both positive incentives for reducing readmission called bundling post-acute care and inpatient services in in pilots, but also sanctions for hospitals that have outlier high rates of hospital readmissions. We have also taken this to the individual hospital level, so if you're not one of the 7,500 people signed up to receive notices every time there are new data elements in the Why Not the Best data system, do sign up. But as researchers, I love this as a research tool. You can get whatever data you want out of these I'm slipping 300 or so indicators that are in the database, most of which come from Medicare's Hospital Compare website, but some of which come from states with all-payer claims data that have added it to this database. But you can pick any comparison group you want, say all the hospitals in your region, all the teaching hospitals in the nation, and see where you are against the top 1%. Again, always focusing on where you can go to increase your performance, and you can look at indicators, whether it's on patient safety or some of the process measures around care of patients with certain kinds of conditions. We now have a little bit of physician data on here. We have the National Committee for Quality Assurance recognition of patient-centered medical homes. So we keep trying to improve this resource as well. Well, let me turn to what it takes to get to a high-performance health system that I feel that research can be helpful with. Certainly, I think having comparative data, even breaking it down, even though people are very excited about this local scorecard with 306, then they want to know within the Detroit region what's the pattern by neighborhood or within these various geographic areas. And then they want to know why those variations exist. And then the theme of this whole conference, what can be done about it? What are the actionable things going on? And for me, since I think we're still at an early stage in understanding it, it's going to the better performers and finding out what they're doing and trying to get ideas of things that might be adapted and work in your area. We put a particular emphasis on research on payment and delivery system reform. Again, I think it's a shift from research on the problem to research on the solution, but it's also finding things that are being tried and then trying to evaluate their impact. So we have a lot of studies currently going on patient-centered medical homes, trying to assess what their impact is on everything from health outcomes to quality of care, patient experiences, but also clinician satisfaction. Is it helping primary care physicians stay in the primary care practice field by making it much more satisfying and doable? Very excited about the bundled acute episode payment. So far, no national visibility, I think, on this, but CMS has announced 4 pilots, 4 different ways of bundling. Some just bundle the post-acute services, some bundle the hospital and the inpatient physician services, and some bundle all of that into a single payment. We have a study that will be coming out in the not-too-distant future, just reviewed it this week, by the Health Research and Educational Trust that's attached to the research arm of the American Hospital Association. They've surveyed hospitals. And there's, to me, one of the take-home messages from that is how much interest there is in the bundled payment method. A little scary yet on the ACO, Accountable Care Organization, jumping all the way with that, but a lot of interest in that. So for specialists in the room, it does mean looking at, say, a single global fee for the surgery that includes the anesthesiology, the radiology, the pathology, and the inpatient, potentially the inpatient part into a single fee. But there just needs to, in my view, to be a ton of research that looks at examples of where this has been tried, because it's not totally foreign to have these kind of global case rate payments, at least for the bundle of inpatient physician services, and what difference that has made. And then, of course, accountable care organizations. We just had announced this week 27 more that have been approved for the Medicare shared savings. And I would say across all of those, something, again, that hasn't had a lot of visibility called value-based purchasing, which is to reward, no matter what the methodology is, those high performers with extra payments to those that reach that level of care. If I had to say what's the next big policy issue coming down the road, it's how to harmonize the way private insurers pay providers with the way Medicare pays providers. This is going to be a huge undertaking in the U.S., but I think it's going to be inevitable. You're starting to see more studies about the incoherence of prices. Sorry to my friends from the Blues here if I'm stepping on any toes, but certainly what we're learning from some of the all-payer claims databases is big hospital systems get better prices than small independent hospitals. Big insurers get better prices from providers than smaller insurers. And so in a given city, a given hospital is paid different rates from different payers. They all have their own negotiation processes, administrative costs. All of that's going to come under a lot more scrutiny, and I think a lot more transparency and a need to move forward. That's going to require a lot of research about how do you get from where we are now to a more coherent system. Testing and spread of innovation. The Centers for Medicare and Medicaid Services has $10 billion over the next 10 years, to knock on wood, whether the funding will continue. But it's an exciting time to really have this commitment to innovation, trying new things, and to fund that, as well as to evaluate, try to get rapid feedback on it. At least on the books right now, there is to be the creation of an independent payment advisory board, which is charged with making recommendations to Congress if Medicare spending doesn't achieve a target rate of growth. How to make that work, to me, is one of the most intellectually exciting issues left in the Affordable Care Act, although the House voted to repeal it recently, so maybe you don't want to bank your academic career on working on that issue, but I think if that can be made to work. And I was very excited to hear this morning this notion from David Kifford that there's a commitment. We've got a better way to pay. We think it'll achieve savings. If it doesn't, we will take rate cuts. So, because CBO, the Congressional Budget Office, will score rate cuts. They understand how that saves money. They're not so sure about how care coordination and high-cost case management and improved transitions in care and how all of that's going to work. But if you've got a backup way of saving money, then they'll give you a credit for that. So I think another untapped area is regulatory relief to spur innovation. I think we've got a whole set of regulations that were set up for one healthcare system, fee-for-service, solo practice, siloed practice. We need to look at ways of having a more positive regulatory system, as well as ways of pulling everything together at the community level to really use the resources that are flowing to that community more effectively for outcomes. So one of the commission's big contributions was a chart. You know, I'm a numbers person, so most of what I do are bar charts, simple little graphs. But we had this report from the commission on organizing the U.S. healthcare delivery system for high-performance care. And it had case studies of 10 models of outstanding examples and all of the elements of what were a good organization of the delivery system, but not a single chart. And I said to Tony Shi, the lead author, you at least need some kind of graph. And he drew this system integration on one horizontal axis and payment integration on the vertical axis. So I have never liked schematics. I didn't do operations research, industrial engineering. I did economics. But this graph has had more power than almost anything we've put out. And it tells a simple message that you need payment reform and delivery system reform, and that they go hand in hand. And since we have everything from solo practices to the Kaiser Permanente health systems, we are going to need to have different payment methods that support the kind of care transformation we'd like to see in those organizations. And certainly under the Affordable Care Act, CMS is rolling out first 32 pioneer accountable care organizations that take what's called two-sided risk. That is, they get the savings if they achieve them, or a good bit of them, but they pay extra if their costs exceed the target. Then the 27 Medicare shared savings plans, somebody have to help me, I think maybe only 2 took two-sided risk. Most of them said we'd like the savings if they're savings, but we're not sure we're ready to go at risk if the costs exceed the target. They have announced, although not the names, the 4 different pilots that they will test on acute episode bundling. And then again, just yesterday, they announced the 8 geographic areas that will be part of the comprehensive primary care initiative. So all of these things that they were to roll out in 2012, they are. So switching to what the Commonwealth Fund does, I've mentioned that we're pleased to be supporting research at the University of Michigan to evaluate what the Blues of Michigan have been doing since, 2004, something like that, with the physician group incentive program. So, we took this very fine work, which still isn't quite out yet, but soon to be out, and put it into this kind of a communication, a one-page slide. So first of all, you get a sense it exists in Michigan. It exists to varying degrees across the state, but you get quickly to the bottom line early results of what impact has this had so far on key indicators that policy officials care about: hospital use, high-cost imaging, emergency visit use. So heard about this innovation, truthfully, at a meeting in Washington, and somebody from Henry Ford says, you need to learn what the Blues in Michigan are doing. So we got on the phone, immediately said, what are you doing? And then we decided, well, we need to find someone to evaluate that, and worked in partnership with the Blues and the University of Michigan on it. Another example of what we're doing is, and this is unusual for us, but we have funded an intervention to convert 65 safety net clinics into patient-centered medical homes. It's in 5 states. It's being run by the QIO, the Quality Improvement Organization in the state of Washington, called Qualis, in conjunction with Ed Wagner at the McCall Institute, who's really viewed as the father of the chronic care model of care. We are funding an evaluation by Marshall Chin at the University of Chicago, and has some very exciting early results there too, that the further you are along the journey to being a patient-centered medical home, the happier your doctors are and the happier your staff are. So that may seem like a minor result, but given the deep dissatisfaction primary care physicians have been experiencing, very, very encouraging. And then finally, I wanted to mention our funding something we call the STAR Initiative, State Action on Avoidable Rehospitalizations. Again, we reached out to a partner, the Institute for Healthcare Improvement, formerly headed by Don Berwick, now headed by Maureen Bisignano, who's also on the Commonwealth Fund Board, to run this initiative in 3 states, Michigan, the state of Washington, and Massachusetts, to work with hospitals in those states to reduce avoidable rehospitalizations. We have an evaluation by Dennis Scanlon and a team at Penn State. This is interesting. We had another project at Yale with Betsy Bradley evaluating something called door to balloon. So, I don't know, the heart attack patient appears at the hospital door, and how long does it take to get them into appropriate treatment. And we got her to add to that the data on the star hospitals. In her survey of hospitals, she found that these hospitals are more likely to have adopted interventions such as enhanced assessment, enhanced patient education, and different techniques that IHI is really working with hospitals to reduce rehospitalization. So even in advance of the formal evaluation way, getting some evidence out there quickly about the effect of that. So just to wrap up, I do think it's a new era in American healthcare. People often think I see the glass half full, and I feel like that's the role of every leader. Who needs a downer, how much progress comes from that. So I tend to see the bright side of things, but I think this is the most exciting decade to be in healthcare. With more change. I know it's butterflies in the stomach for those who actually do have to put themselves on the line to deliver, but my own view is this legislation is really moving us on the path to high performance, changing a lot of the things that have led to poor performance, first and foremost being the high number of uninsured in this country, but also beginning the path toward changing the incentives to deliver better care, get better outcomes, be rewarded for that, but also generate savings. So what can funders, researchers, and policy officials do to help realize this potential? Certainly generating the will and motivating change. Maureen Bisignano often talks about the comparative data generating the will. Once you realize somebody is better than you are at something, the will to get better, and the denial of we can't do that because our patients are, this, that, or the other, just really is important. But then to translate specifically what is critical for the patient, providers, and for families to gain acceptance for these changes. I think it's particularly important for us as funders to be supporting research groups that then apply to the federal government for bigger funding. So even though we're small and even though you need the R01s to survive academically, a lot of what we support, and that came out of that STAR initiative, a lot of those hospitals now are getting grants from CMS. So it was kind of pilot work that helped them position themselves. So helping them tap into funding opportunities that are available, helping them assess and monitor. There's just going to be such hunger to know what's working. So of all of these things that are rolling out, early evidence is so important. And then, again, since I grew up in an academic nonprofit environment, I believe in sharing information, collaborating. If you've got something that makes care better for patients, then sharing it with others. I had one example that Eve didn't let me give before, so I'm going to sneak it in now. But we funded a guy by the name of Joe Auslander, a geriatrician, who published his work in JAGS, the Journal of the American Geriatric Society, but it's an INTERACT is his acronym, to train nursing home staff for how to take care of residents to prevent hospitalizations and treat certain common conditions. And he found a 17% reduction in hospitalization in the 25 nursing homes he used it in. And I said to our staff, it's almost criminal. It's malpractice if we know that something works to improve care for these residents and save money, and we don't make sure the world knows about this. Because I just, feel so for families that have family members with bed sores or other things that are happening in nursing homes. If there's a way to prevent this, we should be out there working. So we are funding him to spread it to 300 nursing homes, and I managed to work it into every talk I give until the whole world knows about the Auslander interact interventions. Okay, enough of that. Getting people together, sharing what works is important. I would also like to just say specifically a little bit, and it's not on this slide, but notes I was taking today about the bottom line for the research community, asking the right question, studying the problem versus studying the solution. Sometimes you do have to learn more about the problem, but try to shift toward studying the solution. And that may mean moving from easy databases, the lamppost, I do this research because I can get that data because it's available, to really trying to collect it. And then emphasize actionable information, what can be done as a result of the research, and then communicating it well. And we didn't use the phrase respected source. Gary on the earlier panel said a little bit about being respect, but it's hard to build up a reputation as a respected source, and it's easy to lose it overnight. So you've got to have your own internal quality control mechanisms to try to maintain that. For academic administrators, and I've been one, and tried to mentor young faculty and told them how many peer-reviewed journal articles they had to have to make it at Hopkins, from assistant professor to associate professor to full professor. But it just seems so, Hopkins is a soft money environment, and I just thought it's so insane. The things we need our faculty to do to survive here, they don't get rewarded for. So if they get grants from foundations instead of R01s, if they spend their time talking to reporters or testifying before Congress, they don't get rewarded. In fact, somebody on this small-minded faculty is going to say, if they're in the newspaper, it must not have been good research. And it just was. So we've got to change that culture. We talk about changing payment incentives for providers to reward doing the right thing. We got to change the incentives for faculty if we want them to do the right thing. So that's my pitch for the, academic administrators. And then finally, for policy officials, I think it's too much to expect them to read journals. So to forget that, it's probably too much for them to read two-page in the literatures from the Commonwealth Fund. They will read their local papers and other papers, so that's an important way. But I would say to them, try to accept invitations to attend policy forums and reach out particularly to the universities and health policy expertise in their own district, and to forge those relationships, because a lot of it is trust, but oral communication. So I talk a lot about the Commonwealth Fund's electronic reach, all the reports we do, but the main thing I always feel with policy officials is they have to hear it. And I always think the best congressional staff person is the person who in the 60-second walk to the floor can tell them what the bill they're about to vote on is about, and the pros and cons of how they ought to be on that. So we do, I said we convene 100 meetings a year that we fund, but we do briefings for congressional staff 6 to 8 times a year. We do this annual meeting for members of Congress. We do always respond to invitations to testify, and we do develop and forge relationships with individual members so that they know what we have to offer, and they do turn to us for that kind of help. So again, just to wrap up, providing technical assistance to healthcare providers, I think, is the big opportunity in this decade. To facilitate shared learning as we gain experience, to actively support evaluations of these pilots, and to continue to look ahead to the new issues that are going to emerge. Got to keep your eye on where the puck will be if you're going to be relevant when those issues surface, and then join with others to forge common cause. And I thought one theme I heard, if we can all focus on what's best for the patient, absolutely everybody, it lines up behind behind that goal. So thank you very much, and thanks very much to my colleagues at the Commonwealth Fund.
Thank you so much, Karen. And I think most people in this room know, but if you don't, Karen is retiring from the Commonwealth Fund. This is her last year. We are quite honored that she was willing to come here on her farewell tour around the country. And I'd really like us all to honor the work she's done in leading the Commonwealth Fund in really a remarkable way. Thank you so much for